Aloha, welcome to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island and ER physician. Today we're going to take up a new topic in our ongoing dialogue about the healthcare challenges in our state, and that's whether or not we're prescribing too many drugs in our state and what the scope of that problem is. I'm joined today by Keith Kamita, Chief Special Agent of the Narcotic Enforcement Division, and Dr. Scott Miscovich, a healthcare leader and a person who runs a very large practice here in the state of Hawaii, who takes care of a lot of individuals who have legitimate pain needs, but also he's seen some of the tragedies that can occur when overdoses happen in our state. It's been in the news. In the past several months, we saw an article written and discussed that said more people died from overdose of pain medications that were prescribed in our state than died on the roads through motor vehicle accidents, both of which are tragedies. So I wanted to bring these two excellent fellows, two experts in this area, to discuss the scope of this problem and challenge with us, to talk about solutions and see where we are as a state. Gentlemen, thanks for joining me.
Thanks.
Thank you.
Why don't we start here? Keith, could you tell us a little bit about yourself and what your role is here in the state?
Sure. I'm Keith Kamita. I'm the Chief Special Agent of the Narcotic Enforcement Division. We're the carekeepers of the Hawaii's Uniform Controlled Substance Act. What that means is we register all doctors and physicians who handle or control medications,
Yes.
especially controlled substances. We also go after anybody who illicitly sells or diverts these drugs. And we're we host Hawaii's prescription drug monitoring program.
Okay, that's very good. So we're going to talk about those specific drugs as we go forward today.
Thank you.
Scott, why don't you tell us a little bit about yourself and what got you interested in this question?
Thanks. I'm a family physician. I'm in Kaneohe, and I have a large practice that consists of caring for the Windward community. I also have a portion of my practice that cares for a lot of injuries and a lot of sports injuries. So I do have association with dealing with people who are in legitimate pain in the state. And I have been doing some clinical work dealing with urine drug testing, genetic testing, and monitoring pain patients. So I have seen the suffering that occurs through pain. I've seen the lost work that it occurs, but you also see the tragedy. You see the tragedy from overdose, you see the tragedy from addiction. And it's a complex problem, but it's something that I feel we have to address as a state.
Okay, so it's very good to have both of you here today to give us your perspectives. What I'd like to do next is, from both of your individual perspectives, one from clinical, you, Dr. Miscovich, and then from a law enforcement perspective, Keith, if you could tell us what you've seen as far as trends, say, for the past 10 or 15 years, what are you guys seeing?
Well, the trend we're seeing is the abuse of narcotic drugs. Drugs like Vicodin, hydrocodone, oxycodone. But you might be surprised at the way we're seeing them utilize it. Instead of taking it orally, we're starting to see them crush it and snort it, inject it, or even smoke it.
Interesting.
So,
And where are the people getting the drugs? Is it through the black market? Are they originally legitimate patients that had a drug problem but now have a lot of prescriptions? Where are the pills coming from?
it's kind of all around. We find that a lot of them get a legitimate prescription. Some of them are forging prescriptions. Some are just buying it on the street.
Okay.
But a variety of ways.
And is it young people or old people?
We're seeing, I hate to say, the middle class right now, or the baby boomer is being our bigger problem.
Interesting.
And filtering down to our kids.
And what about you, Scott? You're there in the trenches clinically taking care of patients every day. I dragged you out of clinic today. What's the pattern been?
I would agree with Keith. The pattern is dealing with the middle class. People will probably be very surprised who it is that's addicted. I mean, these are people that are out there working. They live next to you. They're your neighbors. They're your family members. So I would agree. I don't see it as much in the younger age groups, but I know we are worried that it's starting to reach down more into the school age or high school, college age. We're starting to see more of the stimulants in the college age that are going. And it crosses all socioeconomic barriers. It crosses male and female fairly equally. And trending would be often someone might have started on medication with a legitimate prescription that then, found that they didn't want to live without it, or basically started to get either dependent, tolerant, or even addicted to the medication.
Let me just throw out some rapid questions to see where, what's real and what's not. I've heard of, and I'm an ER doc, right? So I'm in the ER, someone comes in, They might have seen a couple other physicians. How many patients or people who have a big challenge with addiction are doctor shopping? Is that a common occurrence?
In Hawaii, we're seeing it pretty common. Not only doctor visiting multiple physicians to get the same drug, but maybe visiting one physician, and when that physician is, say, on vacation, they'll run to the ER, or they'll run to another doc and pay cash.
Yes. And Scott, is this a common problem? You're very vigilant in your practice, I know. How have you been able to address that?
Interesting. Back in the beginning of 2012, I started a program which is recommended across the country where I did urine drug testing, as is recommended in many places for all patients that were receiving narcotics. And I was quite surprised about patients I thought I knew that were showing me different things in their urine that didn't belong there.
Right.
And these are patients I've known for many years and I care about, and after addressing it, most of them were very straightforward and they were getting medicines from friends, family, or even buying it. So that was one issue. The second issue is that these people are functioning, they're in the communities, they have sources. I think the sources are available, and they'll be open and tell you where these sources go, where they can go to get the medications. The patients will doctor shop, but we have been using what's called the prescription drug monitoring program, where we can log into a computer and look at a pharmacy program to where the patients have been getting medicine, what other providers they've been getting. So from my perspective, I think in my practice that really isn't happening, because we are checking and we are doing regular monitoring of the other, if there's other prescriptions. I will actually print this up, I'll bring it into the patient, I'll sit down and say, listen, here it is. When did you see this doctor? Why did it happen? I found that direct approach and an honest approach is the best way to address this.
I think we're going to dig into that a lot more during the course of the discussion, but would you like to hold up this, this visual aid? This is, Keith brought this with us. This is a map of the states that are engaging or beginning to engage with this program?
Right now we have 49 states participating in some type of prescription monitoring program. The one that is not is being pressured to get on the stick.
Yes. Okay, so we're going to talk about that, because I know that the three of us are a part of a very good work group. We're not going to talk about the other members today for their privacy, but to begin to talk about all of these challenges, I wanted to hold this up. Keith was good enough to bring, forgive me, it's upside down, to bring some of the narcotics that are prescribed. These are Tylox, Lorcet, Tylenol with codeine, Vicodin. So these are what the pills look like, and here's another visual aid so people can see. These are some of the stronger ones: Dilaudid, MS-Contin, Methadone, Demerol, and these drugs are purely by prescription. Is that right, gentlemen?
That's correct.
Okay, so interestingly, Scott, you were saying in our break earlier that 80%, you were telling me, of all prescription drugs, narcotic prescription drugs in the world are being consumed by Americans. Unpack that for me a little bit.
Number one medication consumed on our planet right now is Vicodin. More Vicodin is taken than any other pill for any condition, whether it's an antibiotic or heart or blood pressure. 80% of all prescription medication for narcotics are consumed by the United States, and then the list goes down for other industrialized countries. I think second highest consumption is Canada, and I believe Australia is third. And so it has become somewhat ingrained in our country. And like for example, in our state, I believe, Keith, you can correct me, over about the past 10-year trend that we've recorded, we've seen about a 65% increase in the narcotics consumed in the state of Hawaii. That compares to perhaps, I believe it's like West Virginia had a 625% increase over that same time period.
Wow.
So there are just dramatic increases over a 10-year period that I think healthcare experts and politicians are trying to get a grasp on and to try to control.
Can you, those numbers are just astounding. That 65% increase, for instance, what would account for that? There's not 65% more pain or more injuries necessitating Vicodin prescriptions. What's going on?
Well, I think we are probably bowing a little bit to big pharma. We're bowing a little bit to marketing. I mean, there's a lot of money being made by companies on producing some of these prescriptions, and they have done a job of ingraining it into society, where we had the old adage about 10 years ago was that pain is the fifth vital sign. So, I do believe there's a lot of marketing that did not educate the population as much on the hazards of the medicine as much of the benefits of the medicine. I would have to say, though, that I do also believe there is more pain. And part of it, if you look at the other trend nationally, is obesity. If you look in that same 10-year period, we have gone from, say, 17 to 20%, and depending on which study you go to, upwards of maybe 1/3 of the United States has more weight. If you look at that, you have the same and even higher proportional increase in low back pain. And that leads to more joint pain, more knees, more knee replacements. So there are trends that parallel painful conditions that would warrant some increase, but nowhere near the increase that we're seeing at this date and time.
Okay, and so we're having a healthcare challenge with all these public health issues, and now we have both mixed healthcare social challenge with the drugs. As you've seen this increase in prescription patterns here, and of course it's even worse in other states, as was just described by Scott. What has that meant to the communities around you?
One of the things we've been seeing is in hydrocodone alone, I had in 2013 over 212,000 prescriptions just for hydrocodone.
Wow.
One of the things that we notice is that they're prescribing larger amounts. When we were young and got our tooth pulled, maybe we got 12 tablets, 6 tablets, but we're seeing 20 tablets, 24 tablets. So more drug being prescribed.
That's interesting too. So more prescriptions and more pills, which was what Scott was talking about, because he was talking about the aggregate of the, I guess, 80% of all the drug that's produced.
Right.
And when you see that, does that mean that the people will take all of the pills, or do they make it into other people's pantries?
What we've been seeing is that they hold on to the drugs.
Okay.
And when you do that, if you have children in the house, you also make it available.
Right.
And that's where we see it when we do education in the schools, that some of the kids are telling us, I got it from mom and dad's medicine cabinet, or my friend's mom had some extra pills. So they know where to get them.
And are people selling pills? Is that a common occurrence?
We do have sales. And these drugs,
Yes.
drugs like OxyContin, drugs like hydrocodone, they have value on the street. And what people don't understand is these drugs are as strong or stronger than illicit drugs.
Okay. Break that down for me a little bit. When you refer to these drugs, and you're talking about oxycodone and hydrocodone, these are the prescription drugs. When you talk about illicit drugs, you're talking about?
I'm talking about heroin. If they're going on a stimulant, I'm comparing it against cocaine, methamphetamine.
Yeah, that's a good question also for Scott. So clinically, are you seeing people with drug addiction in the illicit categories more than the prescription categories? How does it break out in society?
I still would say clinically we're seeing that methamphetamine is still our largest problem by a long shot in Hawaii. I think the number of people that are addicted or regularly using or trying to functionally use is, by pure number, is much greater. That was supported by the urine drug testing that I did in my office. So when I was finding illicit drugs, the number of times that I would find cocaine or heroin was small, but by far, probably over 90% of the single illicit drug that was found in conjunction with an opioid was methamphetamine.
So it's so you're saying that it's often though kind of heaped together. So someone might be taking methamphetamine, but they also might have a prescription for pills or have received pills. Tell me about that. What happens to a person?
I think that most of the time they're using these to sometimes counterbalance the methamphetamine, and they'll also be seeking the benzodiazepines, which are relaxants, or try to...
That's like Valium.
Like Valium and Xanax and those things to try to bring them down. And then it's probably not unlikely that they're also getting these to sell those to pay for their other habits.
Right. I'm seeing that in the emergency department as well, where I'm seeing people come in, and I usually see them in the most acute phase of their illness, where they're having a reaction, their blood pressure is very high, they're agitated, there might be acute psychosis. And I'm actually surprised now some days that people are much more, they communicate much more about their addictions. They're telling me right off the bat, Doc, I was doing amphetamines, I was taking meth. But then when I dig into it a little bit, I find that also, like you said, they're taking all these other pills and they maybe ran out of some of the other pills that suppressed these large reactions, and then boom, they get into a crisis. I don't intend to make this a big part of our program, but I will comment also, and I don't know if you gentlemen have seen this, but almost to a person I'm hearing from them that they had been smoking a lot of marijuana and were doing other drugs, and that led to a pattern that was challenging for them. And that's been a concern of mine as well. I don't want to really get into the gateway drug discussion today per se, because I have your expertise on these other issues, but I am seeing that a lot, and to a person in the ER, I've been seeing that. I'm not saying that's reflective of the entire society, but people are taking these drugs a lot of different ways. They're smoking drugs, and I even had an OBGYN call me from Hilo, concerned because they were seeing a rash of overdoses on the Big Island, and kids were taking these pills, crushing them, and putting them into Coca-Cola. Are you seeing and hearing about these stories?
Especially on the Big Island, we had what we call SIZUP, where they'll take some type of a cough medication, Mountain Dew, mix up some type of a narcotic drug, drink it all together, and we've had some deaths because of that.
Oh boy.
Because of that combination.
So the combos, and then people have challenging healthcare problems. You probably see people with other comorbidities, right, Scott, like with diabetes or lung disease or heart disease in their system. You said they're middle class, regular folks, right? Do they get overwhelmed by these drugs? What happens?
Absolutely. Part of it, you have to understand there are different phases of what happens, and you can have tolerance where people get used to the medicine and need more to get the effects. But on the far end, what we really are seeing is addiction, and addiction is where they keep on needing more. It hits a different part of their brain, a different receptor in their brain, and causes a different reaction where they get wellness and euphoria from it. That's a terrible problem, because then their brain will tell them to do anything they can to continue to get more at all cost.
Once people tip into addiction.
Once they tip into addiction. Right.
Just give me an idea, because I've been out of primary care for quite some time now. Of the number of patients that require pain medication for pain, for knees and joints and accidents and what have you, what percentage of people in society tend to have addiction problems?
Statistically, if you look, you'll see the ranges that will go as low as 5% of people on chronic opioids will become addicted. If you look in the addiction literature, I think they're a little more on the right side of that, and they think it could be upwards of 1 in 4 or 25%. I think in my practice now, I would have to say that I think I manage my patients fairly tight. I would say it's less than 5% that I would see, because I try to put the measures in place so don't let them become addicted to medication.
I got it. And Keith, what are you seeing in that regard?
We're also seeing that our pharmaceutical abuser tends to go back to that same drug, even though we put them in jail or even though we arrest them numerous times. They keep going back to the pharmaceutical drug instead of moving on to another illicit.
Okay. Someone had once told me that there were cycles in the state of Hawaii as to which illicit drugs people like. We had a cycle where it was heroin for a while, then we had a cycle where it was amphetamine. Are there cycles with these drugs?
Well, we're stuck in the ice cycle still yet, and but what we're seeing is that they're polydrug users.
Okay.
You're using the pharmaceuticals with the amphetamine, methamphetamine to get a bigger high.
And so for those individuals that might be, as you said, Scott, as high as 25%, are those individuals taking multiple drugs and having big challenges with other things in addition to pills?
I think most of the time they would. I seldom see it's just one single pill for one thing. There's usually going to be multiple pills involved. Again, methamphetamine, I believe in 90% of the cases, alcohol can be involved. So absolutely.
And I think you made a very good point earlier that, and this surprised me when I first learned this, even a lot of people who are taking methamphetamine or ice are often working in society. You wouldn't know they are using the drug once in a day, and it's keeping them on a high for many hours. They have an intense job of some sort, and they're using that illicit drug, and then they're supplementing with other chemicals, caffeine, all sorts of things to keep them going. But they're actually in society, and you wouldn't know it with a significant problem. But once someone becomes a full addict, how many of those individuals are able to still function? What do you guys see?
That's a really good point, and I have these conversations with patients when we do get a positive urine drug test, and they say, "Oh, I was only at a wedding and I did it," or "Oh, I was only with a bunch of friends and I did it." But you see the spiral downward. I feel it's impossible to truly be a functional addict.
Okay.
Over time, people will have relationship issues with family. Their emotions won't be the same. I mean, we know statistically, after the second time someone uses crystal methamphetamine, the architecture of the brain and the brain blood flow changes. And in most cases, it changes permanently. So it is such a dangerous drug because of how quickly it affects different key areas of the brain that it's impossible to be really a functional addict. And I believe most medical experts would agree with that.
You agree?
I agree. What we also see with our addicts is that a lot of times when you talk to them, they say, "I'm not trying to get high, I'm trying to get normal." Because they're at the point where taking the drug doesn't get them the high anymore. It just makes them able to function.
Oh boy, and then you're in real trouble, because I assume that's when people are seeking a lot of drugs. They need to get more and more, and sooner or later there's a lot of crime associated with it. When I talk to people about my experiences in the ER, I tell them almost always, if it's a question of injury or violence against themselves or a significant other or someone else in society, or they crash their car, I can almost always guarantee you there was some substance. It was either alcohol or some litany of pills or something worse. And of course, there's a separate group of people who are just have pneumonia or have other illnesses, basic illnesses. But any injuries, it seems to me these days, are involved with drugs. And I think we saw that also. It was interesting. We were talking a little bit earlier about how overdoses may have passed motor vehicle accidents, but quite a few of our motor vehicle accidents, if I'm not mistaken, had drugs or alcohol.
That's correct.
How does that play out in society?
Well, what we see happening is they're using these drugs, especially on the Big Island.
Yes.
They're driving, they cross over the center line, they fall asleep.
Yes.
And now what I've been hearing is, especially oxycodone, is that they're having difficulty getting the drug.
Oh.
And it may be a litany of reasons,
Yes.
manufacturers cutting back, pharmacies not wanting to carry, because we also see burglaries and robberies now.
Okay. Interesting. Scott, are you seeing more and more people feel desperate about the drugs, or you're taking kind of a proactive action in your practice to get people under control with their needs and just manage their pain from a clinical standpoint. How often do you see someone just in a desperate state?
We had a situation a couple of years ago where unfortunately one of our younger physicians on the windward side passed away suddenly, and he had quite a large practice of patients who were requiring medication that within days, the community had to pick up. And so I was, along with some of my colleagues on the windward side, helped that. But the desperation of some of those calls that were coming in was remarkable. The tears and the, people being out of meds. Now you have to combine that with some of the things you've talked about. There have been a lot of actions that are happening at a federal level that are holding the pharmacies a little more accountable to the amount of medication they're getting in, the amount of medication they're giving out.
Yes.
The pharmacists, being our partners in this professionally, are also stepping up to be accountable for some of the things that are occurring. And so therefore, there are starting to be more checks and balance in place that someone who wants to go in and has a prescription for 300 of something is going to have a higher level proof that this is a legitimate prescription. So I think that combined with, Keith probably would know, but what have we had? 4 or so robberies at gunpoint in
Yes.
pharmacies over about the last 3 to 4 years,
Yes.
where people went in, they bypassed the cash registers, they went right to the pharmacy and said, give me your oxycodone or OxyContin. And that's in our state.
So it's a new currency in its own way.
In its own way, right.
So it's just fascinating. So because we only have another 15 minutes together or so today, I thought maybe now that we've established that it's a challenge in society, that a lot of people are being prescribed strong medications. Some have addiction issues with it. I know there's been a shortage of access to drug and alcohol treatment in our state. Why don't you just begin to run down the potential, I guess, list of solutions that we might look at to make sure that we're focusing on this issue as a good clinical team, and we'll just start looking at what other states are doing. So what are some of the number one recommendations to wrap our arms around having too much prescription medication going out there?
One of the big things is, and what Hawaii has, is we have an electronic prescription monitoring program.
Okay.
It's worked very well. What we need people to do, physicians to do, is to use it.
Yes.
It's a very good tool where they can check prior to their patient coming in to see what he's been doing and to keep him on the right track.
Now this is something that Dr. Miscovich already told us he uses, right? Is it a good tool? Does it work for you?
Yeah, I believe it's an excellent tool, and you know, I feel that it immediately, if we can get it implemented on a broad scale. I think there's statistics, New York and Tennessee have given us statistics over the last 2 years that show since they made it a mandatory program that physicians had to query based on certain parameters, they've seen their doctor shopping reduce 60 to 70% in both of those states. So they've felt it's a big success when they've used it. So I would believe that in my clinical practice. Basically, if I'm checking it, my doctor shopping, as long as it's in the database, is 0.
Right.
Because if the patient has another prescription coming in, I will question them about it. And they need to be, I mean, the thing is, as you said, Josh, in your experience in the emergency room,
Right.
Most of these patients, if you have a good relationship with them, they'll talk to you about it. And they'll say, oh yeah, you know, oh, I forgot to tell you, or oh yeah, I was in the emergency room, or oh, it's a dental procedure.
Right.
And sometimes it is an innocent issue, but other times it's like, you've got to tell me that. I've got to know.
Right, and I think that it's good because as we discuss these kind of issues, a new candor can develop. Of course, there was a period of time where people didn't want to talk at all about being alcoholics, right? Then there was a period of time where the stigma associated with doing illicit drugs was just plain terrible. But now we can have these dialogues because it's frankly, some of these problems have become so mainstream. This is our neighbors or a relative of ours, you know, God forbid, right, that have the problem. So now we can actually talk about them. But by having openness, which I think is what you're describing, we can chop the problem down. Now, just to give people perspective, we've talked on previous programs, we have about 7,000 licensed physicians in the state, about 3,500 or so full-time practicing docs. Those who actually are doing a lot of primary care with big volume, like Dr. Miscovich, much smaller number, 800 or 900 people seeing a lot of patients day in and out. The rest are specialists. Is it onerous? I've spoken with some of the medical associations, we're working with them. My understanding is you can quickly get on this website, see whether or not someone's got a lot of pills or seen a lot of doctors, and then get off of it. How long does it take?
It depends how good a computer are. It's a few minutes.
Okay.
And the way we describe it is they can get a printout that looks something like this.
Okay.
And see exactly what their patient is doing. The next step what we're looking at is to give the doctors delegate authority so that they can delegate the authority to a nurse to check for them. But
Got
that will take law change.
Yeah, well, law change we can do.
That's right.
So I understand it better for our physicians that watch this show. So the mechanism, and it would look something like this. You have your patients coming in, you might have 25 patients coming in throughout the day, of which several of them may be on prescription pain medication. The nurse or the doctor would bring up the website. They would see what their pattern has been, whether or not they got a prescription for 90 pills 3-4 days ago from someone else, from a local pharmacy, and then you could have a discussion about it. Whereas if a physician doesn't go on that program, they would have no idea. So we only have a few minutes left to discuss this issue. So would this be a recommendation that you gentlemen think would solve a big piece of this problem?
I believe so.
Okay, well, let's talk about a few more because it's such an interesting topic. As we'll begin to look at the way other states have implemented this, and we'll make sure that we have everyone's input, but it's very good to have expert input. You mentioned drug testing. Does that make a difference, Scott?
I believe it makes a significant difference. I told you back in 2012, January 1st, I implemented it based on national guidelines and recommendations. And of the first 500 patients or so, I found about a 10% rate of people who are long-term patients. These were chronic patients, long-term patients, and some acute that showed positive. And for illicit drugs or other drugs that they were not getting from a physician, were getting from friends or in other manner.
Yes.
And with time and patience, I was able to get a lot of these people to either stop those medications or address it. You know, this is something that I will never in my career be able to come to grips with, but I had questions about, should I have an age cutoff for when I test or not?
Yes.
I had 3 patients over the age of 70 positive with crystal methamphetamine. I had 12 patients over the age of 60 with crystal methamphetamine.
Wow.
That, for me, was really surprising, and the patients were pretty candid about it. So I'm not saying that everybody is at that age group, but I think it's important. I would have never suspected it. Without testing,
Yes.
I would have never known. So I'm a big advocate. I think most people nationally are advocating. A lot of states are starting to implement it. Now, it's not every single time, but there has to be a reasonable program for when you implement drug testing.
And you have a very comprehensive program. Do some people do random testing? Is that how it goes?
Absolutely. You know, I do immediate testing, and I've actually written a protocol that I'm going to be publishing. But I basically will do an immediate test at the first prescription, and then patients who are on chronic prescriptions would have 2 randomized tests throughout the course of the year. And then also I recommend that if there's any question, then they could be called back in for a pill count, because we are also worried about diversion, meaning that people are getting the prescription and then it's going somewhere else. So yeah, I believe that urine drug testing should be part of what we do.
What other solutions are out there? I've heard some people talk about having a single pharmacy that one could go to. Is that a solution?
One of the things that our electronic prescription monitoring program is exploring is that we have what we call a pharmacy alert system.
Yes.
Where, say, a physician came in and told me, I want my patient only to see this or go to this one pharmacy, that we be able to go into the system and basically or channel him to that one pharmacy.
Got it. And this is just to get some modicum of control
Yes.
over a broader problem. Gentlemen, we're going to have you back on the show, no question, so we can have an ongoing discussion. I think this is one of the most important discussions that can be had, because I'm so concerned about our citizens who are such good people, but once you get trapped in an addictive cycle, whether you're rich or poor, black or white, you know, whether you have Hawaiian ethnicity, whether you're Japanese, Mormon, anybody can be drug addicted, and we want to get people care. We don't want to see people spiral into such a terrible situation where they have to go into jail. So any final comments you'd like to make about the state of Hawaii and what we might do?
Just one of my advertisement is we're going to be doing some drug takebacks where we pick up all your unwanted controlled substance and destroy them for you.
Okay. So that's fantastic. And last comment, Scott?
Probably the most important thing I can say is this is a very complex problem, and there's not one single solution. I think fortunately we statistically are probably one of the best states in the nation for not having this overrun us yet. But I think we are looking at proactive solutions with our working group that's trying to address this from all the medical professionals. And as always, education is going to be paramount, and that's education of the patients, education of the providers, and I think we can tackle it.
Okay. Well, gentlemen, thank you for being here today.
Thank you.
I'm Josh Green with Healthcare in Hawaii, reminding people, please don't do drugs if you can help it. Please seek help and professional support if you have addiction. We really want to help. Thanks again for joining us.